So a very good afternoon, good evening, or good morning to you, depending on which part of the world you are joining us. I welcome you all to the 8th academic webinar of TUGSS Endoscopy. I am Dr. Bhavneet Bhalla. I am the Chief Coordinator for TUGSS Endoscopy. And today I, along with Dr. Path, will be moderating this session. Now, this is the first webinar of 2023, and we are resuming our academic activities after a brief hiatus. So we took some time out to work on expanding the scope of our activities so as to have a greater reach and impact. Now, with the same thought process, today's session is focused on gastroesophageal reflux disease. Now, as surgeons, we have been managing this condition by various operative procedures. However, in this rapidly evolving era of medicine, we must constantly upgrade and update our knowledge and skills so that we can offer the best possible treatment to our patients. Hence, it is imperative for us to learn not just the surgical procedures, but also the different endoscopic procedures for the treatment of GERD. Now, what are these procedures? How efficacious they are, and when and to who we can offer these procedures are some of the things we are going to discuss today. Now, the guest lectures, as usual, will be followed by a Q&A session and panel discussion. I request all of you to type your questions and comments in the chat box, and I and Dr. Parth will put them forward to the speakers and panelists on your behalf. I would now like to introduce today's panelists and speakers. So we have with us today Dr. Abhay Dalvi, who is one of our expert panelists. Dr. Abhay Dalvi is a surgical gastroenterologist at Global Hospital Mumbai and Associate Professor, Department of Surgery at State GS Medical College, Mumbai. Now, Sir is also the past president of Association of Surgeons of India, which happens to be the largest organization of surgeons in India. Sir has also been the past president of Indian Association of Gastrointestinal Endoscopic Surgeons. Now, he is a passionate teacher and has been invited faculty to numerous national and international conferences. We thank you, sir, for joining us today. We also have with us Dr. Praveen Suryavanshi, who is the professor and head, Department of Surgery, and also the deputy dean at MGM Medical College and Hospital, Aurangabad. Dr. Praveen is an accomplished surgeon and endoscopist who excels in both advanced laparoscopy and also advanced endoscopic procedures such as ERCP, OM, and endoscopic ultrasound. So he has been appointed as in charge of the National Program for Quality Enhancement by the Association of Surgeons of India. Welcome, sir, to today's session.
Thank you.
And now it is my privilege to introduce our guest speaker for the day. I welcome Dr. Amit Maydeo, who is the chairman and chief gastroenterologist at Global Hospital, Mumbai. Sir has been a pioneer in the field of therapeutic endoscopy and ERCP, and during his illustrious career spanning more than 3 decades, he has trained a generation of endoscopists and has been invited faculty to numerous national and international conferences. Sir is the president of Association of International GI Endoscopists of India and also the president of Indian College of Endoscopy. In recognition of his contributions to the field of medicine, Dr. Amit Maydeo has been facilitated with the Padam Shri Award by the Government of India. Thank you, sir, for joining us today at TUGSS Endoscopy. I would now request you to start your talk, sir. The screen is yours.
Thank you, Bhavneet, and thank you, Dr. Abhay Dalvi, Dr. Praveen. Both I know very well. Both are accomplished surgeons, and Praveen also is an accomplished therapeutic endoscopist. Of course, even Abhay used to do endoscopy in the past, but then he concentrated more on surgery. Now, this topic is very interesting of GERD. So let me share my slides. Oh, what happened? Yeah. You can see it?
Yes, sir.
So my talk today is on endotherapy of GERD. Just wanted to tell you that to talk about endotherapy of GERD, it's very important to understand something about GERD, whether you're going to treat it surgically or endoscopically or even medically. Now, gastroesophageal reflux disease was considered for many years as a problem predominantly seen in the Western countries. But now with the changing lifestyle of people, our patients living in India or people living in India, we are seeing an increasing incidence of GERD even in our country. You can see this article published in Indian Journal of Gastroenterology in 2019, which states that the prevalence of GERD in India varies anywhere between 7.6% to 30% of the population. Now, just imagine the huge population which we have. Now, this is mainly restricted or mainly seen in the urban population as compared to the rural population. Maybe it reflects their lifestyle, reflects their eating habits. And out of this population, 40 to 50% sort of experience heartburn every month, whereas 20% of the population experiences heartburn almost weekly. If you ask me personally and all the published literature, it states that the classic symptoms of GERD are basically two. One is heartburn, and second is regurgitation. And if these two symptoms are present, only clinically it has got a 70 to 80% specificity and sensitivity in the diagnosis of GERD. You can label this person as GERD if these two symptoms are present, heartburn and regurgitation. However, there can be other type of symptoms also, like non-cardiac chest pain. There can be recurrent dry cough, or there can be dysphonia. Sometimes there can be sore throat or a globus sensation also, something like a lump in the throat, etc. Now, as a routinely, sometimes physicians tend to give some form of anti-acid or anti-secretory medications to see whether they get relief. And depending upon that, they make a diagnosis of GERD. But the overall published literature states that almost 50% of patients may not get an adequate relief with PPI. So therefore, PPI trial should not be used as a monodiagnostic modality for the diagnosis of GERD. And GERD patients should always be treated with a personalized approach. So now, before we go ahead, I just want to tell you, why does GERD happen in humans? If you were to see the anatomical structure of the lower esophageal sphincter, of the diaphragm, the diaphragmatic crura, of the subdiaphragmatic fat pad, and especially over here, if you were to see the stomach fundus, the angle of the stomach fundus, and this mucosal flap which comes down from the stomach fundus, and then it goes out and reflects up as the esophageal mucosa. Now, this is very, very important or crucial, and this is called as the gastroesophageal flap valve, this mucosa. So every time we eat food and there is a pressure which is generated inside the stomach, because the pylorus closes, the OG junction closes, and the stomach is mixing the food with hydrochloric acid. This flap valve closes the OG junction, and therefore, the acid content which is there mixed with the food, and the food itself doesn't come up in the esophagus when the pressure in the stomach is increasing. Second is this acute angle. You see here, the angle of His is very important. Now, this angle of His has to be acute. If this becomes obliterated, then usually the flap valve does not continue to function so well. And so these are all the things which you should remember: the esophagus, the diaphragm, the position of the fundus, the lower esophageal sphincter, the GEJ area, the GE flap valve. And there are seven mechanisms which prevent reflux in a normal human being. The first is the lower esophageal sphincter pressure. The basal ileus pressures should be high. And the basal ileus pressures, when they are normal, then what happens is that itself, along with the pinch-cock action of the diaphragmatic crura, every time during inspiration, that further closes the OG junction. Second is the angle of His and the gastroesophageal flap valve. Third and fourth, after the food has entered inside, because the pressure increases, if the angle of His is properly acute, and if the GE flap valve is in this position, if it has not got obliterated, then acid cannot come up. The fifth thing is the posterolateral location of the fundus. So therefore, you must have noticed that in some patients of GERD, they have a reflux of acid or a heartburn when they change the position of their sleeping. Sometimes in the left lateral, right lateral, the fundus of the stomach tends to fall in the front, and that also causes the reflux to happen. Sixth, and very, very important, is the motility of the esophagus. Even in normal human being, certain amount of acid does tend to go up in the esophagus. But this acid is very promptly cleared because of the normal motility of the esophagus. So if the motility of the esophagus is hampered, this even small droplets of acid which go up may not get cleared, and the patient may experience symptoms of GERD. And seventh, which is many times neglected, not thought about, probably not treated, and not investigated, is the gastric emptying. Now that it has been found out that quite a large percentage of patients of GERD also have an impaired gastric emptying. So because of which happens is that the food and the acid, which is a mixed form, it remains in the stomach for more amount of time than is normally done. So in 3 to 4 hours, the stomach is supposed to empty and the contents have to go in the duodenum and the small bowel. Now, in 3 to 4 hours, if the stomach does not empty, continues to contain food and the acid, which is a mixed, then this can further aggravate GERD. So we have to remember that these 7 mechanisms have to be kept in mind whenever we are treating a patient of GERD. Now, most of the times, physicians start treating these patients by a normal step-up approach. So today in the literature, today in clinical practice, it is more or less sort of practice that all patients of GERD are treated in a step-up manner. Now, what is the meaning of step-up manner? In a step-up manner, number one is these patients have to change their lifestyle, modify their eating habits. So what are the factors which they need to change? Number one is the eating habits. The is most important is to have lesser portions of meal at one time and not to over distend the stomach at one time. Then eating slowly is extremely important, which has been advocated because those patients who tend to eat fast, they tend to gulp the food. Along with the food, they have tendency of being aerophagia, and that distends the stomach even more, and that further causes incompetency of the lower esophageal sphincter. Next and most important factor is to have an early and a light dinner. So the lightest meal of the day for patients who experience symptoms of GERD should be the lightest meal, and the meal should be dinner, and it should be early. That means between dinner and sleeping, there has to be a minimum 3 to 4 hour gap whereby you allow the stomach to empty majority of its contents. After this, the patient is given a PPI trial. A PPI trial with a single dose PPI is normally given for 4 to 8 weeks, 30 to 60 minutes before eating the meal, when the PPI works best. After 4 to 8 weeks, these patients are reassessed for their clinical symptoms. Now, if the symptoms or the response is inadequate, then the same PPIs are increased to twice a day for the next 4 to 8 weeks. And if the patient responds to twice daily PPI for 4 to 8 weeks, and the patient has started following the lifestyle management and the dietary control, then we can start tapering of the PPIs. In normal circumstances, in such a situation, no more investigations are warranted or required. However, now there are two scenarios where we need to do investigations. Number one is as soon as you reduce the twice dose PPI, the patient starts regaining symptoms. Patient starts getting symptoms again. In such a situation where there is a inadequate response and the patient is just not responding after stopping of PPI, we need to perform some investigations. And second is there is a very good response, but keeps on recurring again and again, and patient all the time needs to take PPIs. And if the patient takes PPI, he's fine, but the patient is tired of PPI. So how long do you want to continue PPI? To take that decision, also you need to do investigations. So what are the investigations which are normally carried out? You know, there are two main investigations. And the two main investigations, if you ask me, are number one, an upper GI endoscopy, and number two is a impedance pHmetry to know and to have an objective assessment of GERD and whether it is an acid reflux or a volume reflux, or there is no reflux at all, but it's just simple esophageal mucosal hypersensitivity. Okay, so upper GI endoscopy is done for what purpose? Upper GI endoscopy is done.
Amit,
Yeah,
are
yeah.
you changing slides? Because
No,
your
I'm not
slide is
changing.
constant. Okay,
I'm not
fine.
changing slide. I'm not changing.
Okay,
Just now,
okay,
see, for the medical part, I'm not kept any slides. After I finish
okay,
this, I'm going to start changing.
okay.
So just a little bit left. Yeah. I just wanted to give a little brief overview of the medical treatment. Only then we can talk about interventional therapy like endoscopy or surgery. That's the reason I was talking about this. So on endoscopy, what we want to see is, number one, is to see for erosive esophagitis. Because if there is erosive esophagitis, we need to change the medications a bit. Number two is we need to see the Hills grading of the flap valve. As you know, there are 4 Hills grade 1, 2, 3, 4. 1 and 2 means that the lax esophageal junction, LES, but there is not a very wide crural diaphragm. So here, in such a situation, Hills grade 1 and 2 and Hills grade 3 and 4. Next is what is important to see the presence of axial hiatus hernia, and you have to see for a long segment or a short segment Barrett's metaplasia or Barrett's esophagus. So these are the 4 things which we need to identify on upper GI endoscopy. On endoscopy, you cannot make out impaired gastric emptying or reduced gastric emptying. Second, after this is done, we need to do a pHmetry. In our country, in India, we normally do not have a wireless pHmetry mechanism or wireless pHmetry instruments or which is freely available. So we use a normal wired pHmetry device, and 24-hour pHmetry is done by impedance. And here, the acid exposure time is measured. And every time the patient sleeps or after eating, depending upon the pHmetry will show us what is the time there is acid exposure inside the esophagus and what is the amount of acid exposure. Now, once we have done this, now the time has come for treatment. So if these patients need to continue to take PPIs for a very long time, or PPIs are not having any difference, in spite of taking PPI, patient is not feeling the relief of symptoms, both the times we ultimately need to do investigations. And on investigations, if you see here, these are the things which we can see. This is what is most commonly seen in clinical practice. On the left side, lax cardia. Now, lax cardia is not a big hiatus hernia. It's just a loose junction, and this is called as a scope gripping sign. If you see the OG junction, it is not gripping your endoscope. So on a U-turn, on an endoscopy, when you look inside, this is a classical lax cardia, which falls into the category of Hills grade 1 and 2. Whereas here you have an axial hiatus hernia, there's wide separation of the diaphragmatic crura. You can actually see this is a situation which falls in the category of Hills grade 4 or maybe Hills grade 3 later part. So 2 scenarios you have: normal crural sphincter, but a reduced LES pressure, lax cardia, and absent angle of His. You see here, angle of His is not acute. In a second scenario, you have a widely open crural sphincter. LES pressure may be all right, normal, but there is absent angle of His and altered position of the stomach fundus. Now here, I just want to tell you that only the left side category, that is the lax cardia, His grade 1 and 2, is, if at all, suitable for endoscopic therapy. Anytime you have a situation like this, where there's a wide separation of the diaphragmatic crura, axial hiatus hernia, and patient is grossly symptomatic for GERD, documented on pHmetry, such is the situation, this patient may require a surgical correction. So let's get this very straight, that endoscopic treatment is not for all types of GERD patients. It is only those patients who have got Hills grade 1 and 2, and where you feel that by tightening the sphincter, and you also know that the esophageal motility is normal, only then you can go ahead and perform such type of a procedure by which you can sort of remodel the esophageal sphincter. So now endoscopic therapy for GERD, can be done in two basic ways. Number one is augmentation of the lower esophageal sphincter muscle, or number two is actually remodeling the gastroesophageal flap wall. Now, augmentation of the low esophageal sphincter muscle is done by a device which is called a STRETTA device. Now, STRETTA device is quite a simple device. It's a catheter-based system where you pass the scope in the stomach, leave a guide wire, and over that you pass this device. I'm going to show it to you in the next slide. After passing this device, then you inflate the balloon of this device at the OG junction. And this balloon contains some spikes which come out on the surface of the balloon. Now, when you inflate the balloon, these spikes enter the low esophageal sphincter muscle. And then after the spikes have entered in the lower esophageal sphincter muscle, you apply radio frequency. And then by giving radio frequency application in the muscle, we hope that it causes stimulation and thereby slowly thickening and hypertrophy of the LES muscle. Now, this takes time. The result of the STRETTA, the result of the radio frequency is not immediate, because you may need to do 2 or 3 sittings of the STRETTA, and after 3 months or 4 months, you may see probably a tightening of the LES because of hypertrophy of the muscle of the lower esophageal sphincter. So this is a device which is available in the United States, not commonly used in our country, in India. In some studies, it has been shown to have reasonably good success rate, where almost 50 to 60% of the patients have stopped their PPI medications. But in whichever studies we performed in our country, we have not found very encouraging results. So therefore, we nowadays more inclined towards remodeling of the GE flap valve. Now, how do we remodel the GE flap valve? There are various devices now by which we can remodel, and various techniques. One of the most simplest technique is ARMS or ARMA. ARMS procedure is nothing but anti-reflux mucosectomy, where 2/3 of the mucosa of the lesser curvature in the stomach is resected by a technique of endoscopic mucosal resection. Now, once you resect 2/3 of the mucosa on this portion, when this mucosa which is resected, when this heals, there is cicatrization. And cicatrization occurs on the lesser curvature, and the greater curvature gets pulled up like this, like a sling. Here we have not done any resection. So this is elastic, but there is cicatrization. So it almost looks, if you see here, as if you have performed a lap fundoplication. Now, by doing this technique, excellent results were reported by a Japanese group. And then many centers started following this technique of anti-reflux mucosectomy or anti-reflux mucosal resection. And then the same group, after a few years, published their data. Instead of resecting the mucosa, to make things simple, they did pulsed high wattage APC, argon plasma coagulation, of this mucosa of the 2/3 circumference on the lesser curvature. So instead of resection, they burned the mucosa. I'll show it to you. And of course, we have got some devices like stapling devices, like the transoral fundoplication device, the Muse, and of course, the GERDX device, which is an endoscopic full thickness plication. Now, this is the STRETTA. This is the concept. The device is passed inside over a guide wire. Now, this is the balloon. When the balloon is inflated, these are the spikes which have gone inside the muscle. And then you apply, because there are multiple spikes at multiple points, you apply the radio frequency. And then you see how this muscle has got hypertrophy. Only because of the hypertrophy of the muscle, now by this very simplistic device, you can achieve a tightening of the lower esophageal sphincter. And by this, you see here, there's a meta-analysis which contains 4 randomized controlled trials, 23 cohort studies, 1 registry, almost 2,500 patients. They found improvement in the health quality scores, reduction in the pooled heartburn standardized score, and PPI stoppage in almost half the patients. Reduction in erosive esophagitis in 1/4 of the patients. Not ideal, but very good technique if the patient does not want to continue PPI for a very long time. You can use this simple technique, which does not involve any cutting, any resection, any bleeding, any risk whatsoever. The only issue is that it is expensive. This device itself is very, very expensive. 2 or 3 times you may have to use it over a period of 3 months or 4 months. And ultimately, the results are seen only after 5 or 6 months, because it takes time for the muscle to hypertrophy. Then we come to anti-reflux mucosectomy. Anti-reflux mucosectomy appears now when you saw those pictures as a very simple technique. Then you start wondering why this was not invented and practiced before. Actually, Professor Inouye from Japan, who incidentally happens to be the person who invented the poem procedure, was an expert known before the poem for EMR or endoscopic mucosal resection of Barrett's. And when he did Barrett's resection in the lower esophagus, sometimes these patients also had symptomatic GERD. And if he did circumferential resection, and when these patients developed a little bit of cicatrization, their symptoms of GERD disappeared. And that's what gave him the idea that why not tighten the lower esophageal sphincter by doing a simple mucosectomy. And thereby he described this technique. So what he did is, you see here, enhancing the grade of gastroesophageal flap valve in Hill's grade 1 and 2. So this is how the resection is done, endoscopic mucosal resection. And after the resection is done, this is how it looks after a month because of cicatrization. And the beauty of the technique is that in case it does not tighten too much sufficiently and patient continues to have slight symptoms, you can go in again and do a little bit more resection. And by this, further tightening is likely to happen. So this happens because of healing by secondary intention, scarring, tightening of the ileus, and enhancing the angle of his. So I'll show you how this is performed. We have to attach a EMR cap at the tip of the endoscope. Now I'm taking the endoscope in a U-shaped, U fashion, U-turn, and I am visualizing now the OG junction. Now to do a resection, remember, this area of the stomach, the wall is very thin. You can't just go suck the mucosa and cut it. If you do that, we'll create a hole and a full thickness perforation. So we inject normal saline in the submucosa, similar to what we do in the poem procedure in the submucosa, and lift the mucosa. And then we suck the mucosa inside the cap. And by using the snare, which is an elliptical snare, a special EMR snare, this is how we have resected it. Let me tell you, it looks a little easy, but this is a bloody procedure because this area of the submucosa and this part of the stomach is very, very vascular. Every time you resect, you will find blood vessels which start spurting. So you should be prepared to do an immediate coagulation by using the coag grasping forceps. So as we keep on resecting part by part, area by area, on the 2/3 mucosa of the lesser curvature, we have to achieve a hemostasis of these vessels. So after doing this complete resection, to prevent late rebleeding with a hemostatic forceps, all these exposed submucosal vessels have to be individually caught and properly coagulated. Now, once this coagulation is done, and then we don't do anything. The patient is kept on liquid diet for a little while. Here, I'm going to show you how we do the coagulation by using the coag grasping forceps. So this is how vessel by vessel we are catching it and applying the coag current. And then the patient is kept liquid diet for a few days. Patient is continued on PPIs for a few days, for a month or so. And then after a month, the patient is called for a follow-up. You see here, this is how it looks once you see it after a month. If you were to clean the lens properly and have a look at it, you can see that there is cicatrization in this area, almost like pulling like a sling. And look at the enhancement of the angle of his. Look at this gastroesophageal flap valve. It has become so much prominent now. So therefore, what happens is this can cause an excellent result of refractory GERD, and many patients stop PPI. In fact, recently, just in 2020, you can see this first Indian study which was published on the feasibility and outcomes of anti-reflux mucosectomy for PPI-dependent GERD, first Indian study from our department, 62 patients of refractory GERD. The technical success of ARMS procedure was 100%. Intraoperative bleeding occurred in all the patients, but it could be stopped immediately. Post-procedure dysphagia was seen only in 8%, but almost 70% of our patients stopped their PPIs. Very, very encouraging results. And reduction in PPI in another 11%. So this almost 70-80% patients had a substantial relief. Of course, in some patients, there was no response, probably because the tightening was not good enough. And at 1 year follow-up also, 60% of the patients continued with significant symptom improvement. So it is a very interesting technique which can be used only for those patients of lax cardia, where surgeons also are a little bit reluctant to go ahead and do a laparoscopic fundoplication. Patient is fed up of PPIs. They don't want to keep on popping PPIs. You can go ahead and do this procedure. Well, the same doctor, as I told you, the same physician, he came up with this anti-reflux mucosal ablation as an alternative to the anti-reflux mucosal resection. Because the mucosal resection technique can be a little tedious if you do not know how to do EMR. And here the EMR is done in a U-turn. It is not done in a straight position. So you have to be very, very proficient in this technique to be able to perform it. Otherwise, you will cut haphazardly, you will have no result. Secondly, there will be excessive bleeding, because of which you will stop the procedure. Or if you cut too deep, you may create a perforation. So you have to be careful. If you learn the technique properly, it's extremely useful. But as an alternative, you can do the ARMA, which is an anti-reflux mucosal ablation. Same thing can be achieved by doing deep burning. By using deep burning, we use pulsed APC, argon plasma coagulation. Again, on the lesser curvature, this also heals by secondary intention, and you get such type of scarring over here. And you see, this is the result of the ARMA procedure. And this is how the ARMA is done. You can see now that I'm taking the U-turn, and here we are using the argon plasma coagulation. First, we do a marking of a horseshoe. That means the area which we want to burn. So we are marking, we are going to do by this knife, which is a triangle tip knife. And then after the marking is over, then we take the APC probe and we start burning the mucosa. So we can either use the APC probe or we can burn the mucosa with this knife itself. So we go take the knife nearby and we apply a forced coagulation current. You see here, what we are doing is we are intentionally damaging the mucosa, sort of putting a little bit damage even to the submucosa. There were some endoscopists who preferred to give a submucosal injection of saline and then do this procedure, but none of us prefer it, because if you do that, we will not cause a sufficient scarring of the submucosa, and the result will be not as robust as the anti-reflux mucosal resection. You see here, this is how the burning is done. And at the end of the procedure, this is what you see. You can see the amount of damage which we have done to the mucosa and submucosa in a horseshoe fashion. Now, once this scars, you will get an excellent results of tightening. So clinical results of ARMA, only initial study, 12 patients of refractory GERD, technical success 100%. You see here discontinuation of PPI, again, that's almost similar, 60%. So those of the endoscopists who are not very proficient with the EMR technique can proceed and perform this procedure. As a corollary to this, Professor Inouye has recently introduced a new technique which is called ARMS plus C. That means they do anti-reflux mucosal resection. They resect the mucosa, and then by using a loop and a clip technique or a suturing device, they close the lesser curvature, the mucosa to mucosa closure. Now, when you do a mucosa to mucosa closure of the lesser curvature, the area which you have burnt or area which you have resected, that causes a very strong bonding, because now you have made a raw surface and now you're closing it. It fuses very strongly, and this is much more durable than the normal ARMS procedure. Then we come to this, which is making big waves now as far as endoscopic therapy of reflux disease is concerned. That is endoscopic full thickness plication using the GERDx device. Now, this device was sort of launched many years back, 2018, by this German physician, where he published this first prospective trial and clinical feasibility of the new full thickness endoscopic plication device. You see here, this device has got a handle. It's very big, thick. It's bigger than the shaft of an endoscope. And at the tip of this device, there are two arms. At both the arms, we can attach staples. One side is the staple, second side is the receiving end of the staple. And this is a pledget on the other side. So this device is passed inside the stomach over a guide wire. So you have to first pass an endoscope into the stomach, leave a stiff guide wire, and over this device is railroaded. After railroading, through the device, we pass inside a ultra-thin endoscope. So you take out the guide wire and you pass an ultra-thin endoscope, because this device doesn't have any optics. So the endoscope comes out through the device over here. And the endoscope is also take a U-turn is done. So the device is turned in a U-shaped fashion. The endoscope is turned in a U-shaped fashion. And you can actually see the OG junction and where the staples are going, you're going to put. So you see here now, I'm going to show you the technique of the endoscopic full thickness plication. So I'm going to explain to you this device now. I'm holding the device in the right hand. And here you can see that there are two arms. I have not yet put the staples on the two arms. So what I'm going to do now is, this is the way we hold the device with two hands. And this is the lever. By moving this lever, we can bring it in the open position, the closed position, and the fire position. And by rotating this handle, there is a 1-2 transmission of or rotation till the end, and you can go at any part of the OG junction by rotating it. So now first thing I'm doing is show you how this device can be made into a U-turn by turning this knob. So by turning this knob, you can turn the device and turn it towards the U. Then I'm going to show you how the arms are opened. So to open the two arms, this lever has to be turned. So you have to turn that lever, I'm showing you now, push it ahead, and then we move the lever towards one side, towards the right. And after that, I'm going to press this. After pressing it, you can see that the arms are opening up. Now, once the arms are opening up, then you put the staples. And in between the two arms, you look at this channel here. There's a small channel here. And through this channel, we can pass a screw type of a device. That is called as a helix. So what is the necessity of that helix? First of all, you see the staples. This is a double staple here. And here is the pledget. So the staple enters the pledget through and through the tissue, full thickness. And through the center portion, what I'm going to pass is, I'm going to pass a small helix, which is actually like a screw. So what is the necessity of this? To pull the stomach wall between the two arms. So after we have taken the right position, I'm going to push the screw ahead so that the screw enters the stomach wall, and then the stomach wall is pulled in between the two arms. After pulling the stomach wall between the two arms, we rotate the device and close the two arms. So now here I'm going to demonstrate it on a sponge. You have put the sponge between the two arms and the two staples, and then I'm going to put it in the firing mode, and then we fire the staple. Now after firing the staple, I'll just show you, this is how it looks on the sponge. So now let's see in a patient. So first an upper GI scopy. Identify where you want to put the staple. This is the lesser curvature, lax cardia, that's the greater curvature. The next step, we go in the antrum of the stomach, and we are going to pass a guide wire. This is a special guide wire which is very stiff because the device is very thick. So this guide wire has got a flexible portion at the tip and also a flexible portion proximally. So we leave the guide wire inside and gently start pulling the endoscope out. Then the endoscope is pulled out. And once the endoscope is pulled out, over this guide wire, now we are going to load the GERDx device. So this is how the GERDx device is loaded. The wire is gone through the channel of the GERDx device. It comes out over here. You know, wire is being passed inside. It comes out from here. We keep on pulling the wire on one side, and the device is passed as if you are doing an upper GI scopy, slowly passed across the throat very gently so that you don't damage the throat because it is a very big device. This procedure is done under full endotracheal anesthesia. So now see, I'm moving this device up and down like a scope, and with a proper feeling, you have to pass the device until you get a good give way across the throat until it goes up to almost 50-60 centimeters, which are markings on the device. Once we have gone in, I'm going to take out that guide wire, and then I'm going to inflate the stomach by this cuff. This is like a manometry cuff, like a BP cuff, which is attached to the device, and I'm going to inflate some air in the stomach so that we can see the OG junction properly. Then we add lubrication gel or silicone oil in the channel, and I'm passing this ultra thin endoscope. You can see now this is the vision through the ultra thin endoscope, which is going in the device. We pass the scope inside, keep on passing it until you enter the stomach. Once you enter the stomach, Now we start seeing the fundus, and at the same time, now I'm going to move this wheel and turn the end of the device and bring it towards the OG junction. Can you see it now? How it has come towards the OG junction. And with the ultra thin scope, I know exactly where we are. Now we decide where we want to put the staple. You have two choices. One is we can put a staple here itself, or we can put a staple on the lesser curvature and tighten this portion as you saw in the arms of the ARMA. But this is a safer thing to do, because here sometimes if you go too deep, you may sort of damage a tributary of the left gastric artery and the patient can have bleeding. But in this particular case, I'm going to do a partial lesser curvature plication. So I've turned the entire device on the lesser curvature area, and now I'm going to open the arms of the device. So now after opening the arms of the device, I'm trying to bring it in the right position to decide which part of the stomach wall has to be pulled between the two arms. So somewhere over here I want to go. You should never go in the esophageal mucosa. Always catch the stomach mucosa. So you see here now, go a little bit near, and I'm going to push and rotate this screw so that it goes deeper inside the wall. So I'm going to go in now, rotating, so that now it gets fixed very firmly. And now we pull. And after pulling, we bring the device little bit nearer. And once you feel that you're in the right position, see, this is how we close it. Now don't fire it, just close it, and we just see how it is. And then once you know that you're in the right position, we bring this lever to the fire position and then fire. And before that, you have to release the screw. It's important. If you don't release the screw, then the whole device will get stuck. So you see here now that we have fired it. After firing it, now I push it away, and you can see how nicely you have achieved this plication. So this is an endoscopic full thickness plication of the lower esophageal sphincter. And then after the procedure, we come out. Normally one staple is also enough, but sometimes you can use 2 staples or 3 staples if you feel that the OG junction is too wide. But in this particular case, you can see here that after doing the endoscopic full thickness plication, now I passed in a scope, and it looks almost as if you have done a lap fundoplication. The surgeons will agree with me, because you can see a rotation also, because after the staples have gone in, I've rotated the device. And this way, what happens is there is an excellent relief of the GERD symptoms. In fact, this, you can see here that first randomized sham control trial was published on the endoscopic full thickness plication for the treatment of PPI dependent GERD. 70 patients were randomized, 35 in the EFTP group, 35 in the sham group. Median age was 36. And you see here the Demister score, this is what before, but again, 62.8% stopped the PPIs at 12 months, and in sham, only 11.4% stopped their PPIs. So therefore, this is one of the most robust modalities by which we can treat patients of Hill's grade 1 and 2, but who have got symptomatic GERD and who are PPI dependent and who want to stop their PPIs, because if they don't take their PPIs, their quality of life is considerably disturbed. So in conclusion, I just want to state that the various options are now available for PPI dependent GERD. Of course, first and foremost is lifestyle management and a step-up approach. Only if all this does not succeed, or if the patient continues to be addicted or requires PPI on a long-term basis, then you need to do investigations. Objectively, you have to conclude that this patient has got abnormal acid exposure. You have to be sure that the esophageal motility is normal, and only then we can perform various therapies for GERD. So pre-procedure evaluation of GERD Q score, pH metry, HRM, an ideal candidate is Hill's grade 1 and 2, and maybe 3 if there is surgical refusal, and complications of any of these procedures can be avoided by proper patient selection, and of course, learning the technique properly from an expert. Future development is going to be more durable full thickness plication technique, because as a admission, I just want to tell you that I am myself a surgeon. I used to do lap fundoplication in the past and open fundoplication in the past. Last 30 years, I'm doing endoscopic therapy, a hardcore endoscopist. I've tried all endoscopic treatment modalities, but let me tell you that esophagogastric junction is a continuously mobile area. With every breath, the diaphragm is opening and closing. And this is an area where any sort of closure you do or remodeling you do, it is likely to loosen up over years. In fact, all of us know that even laparoscopically done fundoplication opens up after a certain number of years, and the patient continues to have recurrence of symptoms. So endoscopic therapy, even though it appears attractive and it can be utilized for mild GERD or grade 1, grade 2 Hill's grade flap valve, uh, we are still waiting for more durable full thickness plication techniques, which will last longer and possibly which can be repeated quite safely and easily. Thank you so much.
Thank you so much, sir, for that excellent talk. I'm sure, along with me, everybody has just been listening, spellbound to what you have been sharing with us. As always, a very clear and a precise and concise, yeah, comprehensive talk, as always, sir. Thank you so much, sir. Okay, I'll now open the forum for Q&A and panel discussion. So I would invite Dr. Abhay Dalvi and Dr. Praveen to go ahead and any comments, sir, or any queries before we take on the questions from the delegates?
I would like to come in here. Amit has been my schoolmate, classmate since I think 8th standard, and I've seen him grow over the years with endoscopy, starting with Kolhapur, then Mumbai, and then becoming a big man in endoscopy. He has only touched upon GERD, but I have also witnessed him do a endoscopic fundoplication where I was in the OT. So I would request Amit to actually little bit talk on endoscopic fundoplication that also you do for hiatus hernia.
Yes, so this actually almost mimics a laparoscopic fundoplication. It's a little bit different though. There, what we do is this technique was devised basically for patients who had GERD after POEM. In fact, GERD after POEM or abnormal acid exposure after the POEM procedure, if you were to do only pH metry studies, is seen in almost 47 to 50% of the patients, though only 10% are symptomatic. So what happened is, as rapidly POEM became favorite and POEM became famous, equally rapidly POEM started getting a bad name because of GERD. And I'm telling you that many surgeons started blaming the endoscopy that left, right, and center, you guys are doing POEM, but 50% of your patients are having abnormal acid exposure and you're exposing them to further complications of GERD like Barrett's and malignancies. So therefore, Professor Inouye modified the technique of POEM. And what he did is we did an anterior POEM. Now, you know that in POEM, what we do is we cut the full thickness muscle at the lower esophageal area. Circular as well as longitudinal muscle fibers are separated, and esophagus doesn't have a serosa. Esophagus has only adventitia. So at the LES, anteriorly, if you go below the diaphragm, you start seeing the subdiaphragmatic fat pad. And then you start dissecting slowly in the subdiaphragmatic fat pad anteriorly. That is at 11 o'clock position in the POEM procedure. And after dissecting anterior fat pad, our endoscope can be easily passed in the peritoneal cavity. And with that, we go with the endoscope in the peritoneal cavity. You can see the lobe of the liver. Then we take a left turn, you see the fundus of the stomach. Then you can actually grasp the fundus of the stomach with a grasping forceps and pull it inside the tunnel. And you pull the fundus of the stomach inside the tunnel and fix the fundus in the tunnel by loops and clips. And then close the whole tunnel. With this, what happens is you have created a fundoplication during the POEM itself. But this is a very cumbersome technique, and you need a lion's heart especially for a gastroenterologist to enter the peritoneum and see the fundus, catch it and pull it in the esophagus. So not easily practicable. And because of loop and clip technique, it is again not very durable because that clips can loosen up because of the movement. So Inouye started suturing now. In fact, last few cases, Dr. Abhay, I passed the endoscopic suturing device through the tunnel of the poem, and I passed that device inside the stomach, outside the peritoneum. I mean, in the peritoneum, outside the stomach, and actually took a suture in the stomach and sutured that same thing to the esophageal muscle. It has worked very well, but every time I was passing that device through the tunnel, really, my heart was in my mouth, because that device is very cumbersome, very big at the tip. And one tear here and there of a submediastinal structure would have landed me in deep trouble. However, this is an evolving method. So this is what we guys are doing now ahead. And as I told you, as we go ahead, even for large hiatus hernia, we see the hiatus margin, which is separated. We can bear it completely and take a suturing device in a U-turn and actually suture the crura of the diaphragm to each other. That is also a possibility. So maybe that will be the next thing which I will show you after one more year.
Don't take away too many things from our hands, Amit. Your
So
hands are excellent. That much I can
I
tell
think
you.
that's where the things are headed, sir. Fundoplication and GERD management is moving out of the scope of surgeons and moving into the kitty of gastroenterologists.
That I have no objection to it at all. With Amit in place, I have no problem. Praveen, you can come in.
Yeah. So excellent talk, sir. As you said that, in most of the cases in type 1 and type 2 heals grade, you are doing these procedures. So do you exclude other factors like H. pylori infection, all that, or the mucosal hypersensitivity for the acid? So how do you assess that, manage that?
Definitely. See, first of all, as I told you, number one is we are objectively assessing that there is abnormal acid exposure in the esophagus. That is a compulsory thing. Because on pH metry, if you don't find abnormal acid exposure, and if you go and do this procedure, you may not find any result.
Exactly.
Second is, in those patients who don't have acid but have symptoms, that could be because of hypersensitive esophagus. So they have to be treated with neuromodulators. So these are the patients, we treat them more than PPIs, but we treat them with pregabalin. And pregabalin works effectively in these patients. And once the neurosensitivity is done, sensitivity is reduced of the esophagus, then usually these patients don't need any PPIs. All that they have to do is a little bit lifestyle modification, like eating less portions of food.
Right.
And you said that 7% patient of your arms had
Dysphagia.
dysphagia. So how do you manage them, with dilatation or?
Oh, balloon, yeah. We just do a CRE balloon dilation. With that, the dysphagia goes away. Because these are
again, whatever we had done
opens
up everything again.
Yeah. No, we don't open it up too much. What happens is this is already a cicatrized area, and the balloon is not inflated too much. Only up to 12 mm, 13 mm. You don't have to inflate it up to 15 mm on 20 mm. Otherwise, you have lost the purpose. You have defeated the purpose.
Right. So there are a couple of questions from our audiences also, but I would like to ask a question first. So GERD is now a very common problem after a sleeve, bariatric sleeve I'm talking about. So any role of endotherapy has been explored in that area, sir, to give relief to the patients developing GERD after a sleeve?
Same thing we do. Actually, the GERDx device cannot be used after a sleeve because there is not enough room in the stomach. The remnant stomach, you can't take a U-turn with that device. But with an endoscope, you can take a U-turn in majority of the times. Then we can do the arms procedure, definitely.
Arms and arms, right.
Yeah. Sometimes you can do the arms procedure end on. That means looking from up instead of taking a U-turn. That is also a possibility. So as we go there, you look at the OG junction, you identify which area you want to resect of the mucosa, you resect that area, and then you can suture it by using a suturing device or just leave it for secondary intention healing. That's useful.
And secondly, sir, you have mentioned that you basically do a horseshoe-shaped ablation.
Yeah.
So why not a 360 degree? Why a horseshoe shape?
Oh, 360 degree will cause a stricture. We don't want a stricture. We want normal mucosa also, which will act like a sling. We want cicatrization on one area and normal mucosa on one area. You know, our aim is not to form a stricture of the esophagus. Our aim is to tighten, remodel the whole alias.
Right, right. And there's a question from Dr. Roop Jyoti Datta. He's asking, can we use multiple bandings instead of doing a mucosectomy or will that work? And
that may also work, but only banding is not effective. You have to do band followed by resection, because you have to create a defect there.
Right.
A nice wide defect has to be created so that that will sort of heal and fibrose with secondary intention. I think Abhay wants to say something.
Yeah, Amit, how do you choose a patient for ARMS against ablation?
Actually, this is an alternative. ARMA ablation is an alternative to ARMS. And
but is there any selection criteria for this?
No. The selection criteria is expertise of the endoscopist.
Okay. One more question I have is, often after laparoscopic Nissen fundoplication or even toupee, patients have bloating, which indicates that there is gastric emptying problem. So how do we actually evaluate these patients for post-GERD correction, prevention of gastric emptying? What would you suggest? Every patient should undergo a gastric emptying time?
Ideally, yes. But you know that gastric emptying time nuclear study is not so sensitive, if you ask me. That gets positive only if there is a grossly prolonged or impaired gastric emptying. In those patients who just have some bloating, postprandial bloating, and is the early impaired gastric emptying, your nuclear study may be negative. It may be normal. So there are some special non-invasive gastric emptying tests available now. One is electrogastrography, like ECG. EGG is available in our country. So we can do electrogastrography, by which we will know the pressure contractions of the antrum of the stomach. That will tell us the gastric emptying time. And now there is a non-invasive breath test for gastric emptying, a spirulina breath test, which is commonly practiced in America. Very commonly practiced, is usually used for bariatric endoscopic procedures. In fact, this they used to show that after an endoscopic sleeve gastroplasty, you reduce the gastric emptying and the patient has satiety. Patient does not feel hungry for 7-8 hours after doing a endoscopic sleeve gastroplasty, ESG procedure. Right. So that is something which we are going to start very soon in India.
Very good, Amit.
A breath test for gastric emptying.
Very nice. Keep it up, Amit. Thank you.
Thank you.
So I think we are almost out of time here. So before we wind up, I would ask Dr. Parth to mention a couple of things for our delegates. Parth, go ahead.
Good afternoon, everyone. It was wonderful to listen to all of you. I would like to announce that the next session of TUGSS Endoscopy will be held on the 2nd of April. We are holding sessions once in 2 months. So the next session will be held there. We would also like to invite all of you to join our WhatsApp group for regular updates. And the certificates for attendance for today's session will be emailed to all of you, along with a link to the feedback form. So we request you all, we would like to hear from you all. So that's it. It was a wonderful, pleasant Sunday listening to Dr. Maydeo sir as usual. And I've learned a lot. Thank you all for attending.
Thank you, Praveen.
Thank you, Bhavneet.
Thank you, Bhavneet.
Thank you, sir. Pleasure having you.
Back home from Massicon like me. And thank you, Amit. I've learned a lot. That much I can tell you. Thank you. Gives me more opportunity give me more opportunity to refer more patients to him.
Thank you.
Thank you.
Bye.
Thank you so much, sir. Thank you so much. Good day.